Welcome everyone to MGB Global Health Grand Rounds. I'm Joe Radigan, and it's my distinct honor and pleasure to introduce our two speakers today, both close and dear colleagues. Dr. Phuoc Van Lay is graduated from Dartmouth College in 2000 with a double major in biochem and molecular bio and Asian and Middle Eastern languages. He then matriculated at Stanford Medical School, where he earned his MD. During his time at Stanford, Dr. Lay also obtained his MPH from the University of California, Berkeley, with a focus on global health. He completed a combined residency in internal medicine, pediatrics, and global health equity at Harvard's Brigham Women's Hospital and Mass General Hospital. Currently, he's a professor of medicine and pediatrics at UCSF, and he co-founded the HEAL Initiative in 2015. Our other speaker, Dr. Shamasunder, is a professor of medicine at UCSF as well, and co-founder and faculty director of the HEAL Initiative, along with Phuoc. The HEAL Initiative works in the Navajo Nation in 9 countries around the world. Currently, the HEAL Initiative has over 180 fellows, and you will be hearing more details about that shortly. Sri was awarded the Young Physician of the Year Award in 2010 by the American College of Physicians and an Asia 21 Fellow by the Asian Foundation in 2012. He's a Fulbright Nehru Scholar in 2012, and he also was an Emerson Dial Fellow in 2021. Sri, amongst other things, is also a published poet. Thank you, Phuoc and Sri, for being with us, and we look forward to your talk about the HEAL Initiative.
Thank you so much. I'm going to start us off. Would it be okay if we take a look at who the participants are, since we're just to see who it'd be nice to acknowledge folks that who have taught us or mentored us through the years. Oh, great. Well, thank you so much, everybody, for joining. I see some folks who taught me personally during my residency here, or advised me and mentored me. So thank you so much for joining, and look forward to your questions and feedback. So today's talk is called Embedding Equity in Global Health Fellowship Training. This is our experience at the HEAL Initiative at UCSF. And yeah, we would in particular love your feedback on how we can iterate the program to center equity even more. Next slide, please. So we have, Sri and I both have one disclosure to make. So we're both co-founders of ARC Health Public Benefit Corporation. I'm the board chair, and both of us own stock in ARC Health PBC. We're not going to talk about ARC Health today, but just to let you know, that is a disclosure of ours. We always start off our talks with a land acknowledgement, and we are all sitting here on Pawtucket land, and we often acknowledge the land, and I'm trying more and more to encourage people to think about land rematriation where it's possible. Next, please. Today's learning objectives is firstly to talk about and critique the historical and mostly current North American-based global health fellowships model. And when I talk about global health fellowships model, we're talking about post-residency training or training post-complete clinical training, whether it's nursing or MD or dentistry. What we mean is you're done with all your training and then you do a fellowship, rather than the myriad other global health fellowships that include undergraduate folks as well. We're not talking about those. And then we'll go into detail and critique our own model for the HEAL Initiative. And finally, and Sri will be talking about 2 things, mostly the impact, the potential and the real impact of a solidarity fellowship program like HEAL. We think solidarity oriented during a humanitarian disaster like COVID. And then Sri will also talk about future directions of HEAL. So before I talk about how HEAL started, I'll just present to you and see if you agree that the typical global health fellowship model nowadays, if you're in the global north or North America, is usually a 1 or 2 year training. This is outside of, let's say, NIH funded fellowships or specialty fellowships that include a global health component. I'm talking about the maybe between 100 to 200 global health fellowships out there that are non-ACGME. Let me know if these terms need to be explained a little bit more, but non-ACGME fellowships. The typical route is that the fellow is recruited, works clinically at a home-based academic medical center for somewhere around 50 to 75% of the time, which that clinical revenue that's earned to the institution through the work of this attending level person then allows that person to spend a small amount of time, usually way less than half of their fellowship time, in the quote field where there are potentially partners in an LMIC setting, global South setting, and then there's usually some sort of a typically research project or quality project, plus minus a advanced degree if the program is 2 years in length. So that's the very, I think, if you agree with that, that's the current model of the vast majority of global health fellowships out there. And that's exactly what we did in 2012 when we started the Global Health Hospital Medicine Fellowship at UCSF. When Sri and I first met at UCSF, we started imagining how we can contribute to global health training. And within about a year and a half, we developed the Global Health Hospital Medicine Fellowship, which looks very similar or exactly the same as what we mentioned. Folks were working 6 months a year at UCSF as a hospitalist, and then they were spending, actually, they were in INCH, in Haiti, working at the PIH partnered hospital in INCH, and the other fellow was working with Last Mile Health in Liberia during those other 6 months. We did that for a couple years, and based on a lot of our own reflections and our own feedback from partners, we started to develop the HEAL model. And in 2014, the story goes that we brought our boss, Phuoc, who then was the chief of the division of hospital medicine at UCSF. We brought him on a visit to our then hospital medicine fellows to Haiti. And at that time, we pitched the idea of a more equity-focused global health fellowship that would have what we think is the centerpiece, which is the site fellow. And I'll go into details about the model momentarily. Next slide. This is HEAL's mission. We believe in the transformation of systems through transformation of people, and that's through our fellows. So we don't work directly with health systems. We work with people who are within our partner health systems and support their transformation during the 2 year fellowship. Here are a list of our values. Many of them are very similar to the values of the folks on this Zoom call and in this room, and the impact of partners and health values on Sri and myself. Next slide. And this is our theory of changes, is transformation, building this community. And this graphic, we start with a very diverse community, and our set of fellows, which is around 20 to 25 per year, is by almost all measures the most diverse at UCSF. We have the most URM. More than half of our fellows are identified as URM. Professionally diverse, we have multiple non-MDs, although half of our fellows are physicians. The other half can be any healthcare profession. We've had respiratory therapists in our fellowship. We've had dietary nutritionists in our fellowship, dentists, and many others. And then through a really intensive curriculum based on 4 pillars: advocacy, leadership, power and privilege, and structural competency. Those 4 pillars, we deliver several hundred hours of curriculum over the course of those 2 years in the fellowship. The majority of the fellowship is essentially immersion based. So the fellows are doing the work day to day, i.e. taking care of patients, doing the work of delivering care, but the curriculum is layered on top. And then, of course, our really big focus on community of practice. So here are the elements of the fellowship. We have, aside from what I just mentioned, we also have professional development, which includes the option to do an online Master's of Public Health that HEAL pays for. We've also had fellows who have come in with MPHs, and they would opt to potentially do another degree granting program like an MBA, MPP. We've had fellows do DRPHs. And we give fellows up to 5 years to complete their degree. Even though the fellowship itself is 2 years, we allow them a long tail of time to complete the degree. And we've had fellows actually complete PhDs as well during that time. Okay, so here's the rotation model. We have what we call rotating fellows, which are the traditional folks who are often recent residency grads. We've had more mid-career people, but probably I would say the majority of them, Sri, are within 5 years of completing their residencies. And we pair them. So let's say if Sri and myself were 2 rotating fellows signing on to HEAL, we would be paired in a domestic health equity partnership and then an international health system. So, for example, let's just say we would pair to go to Gallup. Well, Sri would spend 6 months in Gallup, while I would be, let's say, spending 6 months working for Last Mile Health in Liberia, doing clinical work, QI work, teaching, whatever the health system demands of us. And 6 months later, we would swap. Layered on top of that experience, of course, is the curriculum that HEAL would be delivering, the MPH coursework as well. At the same time, this is where the equity piece is embedded. The site fellows, good morning. Each of our partnerships, of our partners, the Gallup site and the Liberia Last Mile Health site, would select their own site fellow. And these folks could be any profession, meaning any healthcare profession, from community health worker to physician. We've had district health officers, district medical officers join that as well. They would not be rotating. They would stay at their site because they'd be employed by Last Mile Health or with Indian Health Service. They would continue their work, but then the exact same curricular elements of HEAL and the MPH would be layered on top of their work. So it is quite a busy 2-year fellowship because people don't get a break from their daily immersive work. Does that make sense? This is, I think, the most confusing part of the fellowship. But it also is what bakes in and centers equity, because we, by structure, embed at least half of our fellows are from the Global South. Or Navajo Nation, yeah, depending if you identify that as, an LMIC, right? Okay, next. Okay, so here are the 2 years. This is a little bit of a complex slide as well. We start the fellowship with a 2 to 3 week in-person training, and we bring all of our 20 to 25 fellows together from around the world, 9 different countries, to a very secluded area in the Santa Cruz Hills, beautiful and without Wi-Fi and without the ability to use their cell phones, and they share a big cabin for 2 to 3 weeks, and that's part of that. What we think is the secret sauce to making the community of practice really congeal at the very beginning. So you can imagine the challenges during the pandemic without being able to do that. But that's, I think, one of the big components, and we deliver the 4 pillars of our curriculum during that time. Then fellows go back to their health systems to do that immersive patient care work. 6 months later, the rotating fellows will switch sites. And at the end of their first year, fellows, we bring all the fellows back. We traditionally have done the week-long training at the end of their first year in Navajo Nation at Diné College, a local Navajo-led community college, or actually a 4-year college. And then at the very end of their fellowship, we bring them back together again for another week. During the 2 years, our site fellows have the opportunity to do a site exchange, so they can apply to HEAL to do a South-South exchange. So for example, a fellow in Chiapas could want to go to rural India, where we have a partnership and other HEAL fellows, and they could go for a week or more to learn about their global health innovations or healthcare innovations. We've had fellows go from Liberia to Nepal. We've had fellows go from, where else, Sri?
Haiti to India.
Haiti, yeah.
So, I mean, I think that's one of the strengths of HEAL, because you have such a diverse community. The site fellows that are from the Global South were, probably a couple of years in, we're saying all these folks are rotating. I also want to see what's going on in other contexts. And so actually the community drove these site exchanges. So we have a lot of pieces where you have such a diverse community that are shaping the model as we go.
Right. Any questions yet? People on Zoom? Okay. All right, so this is the 5 ways we are different. So I think I've already mentioned a few times now, the site fellow is what we think centering the site fellow is probably the largest part of our equity commitment. So this bidirectionality, the site exchanges. We have what I would see as one of the most, if not the most, professionally diverse global health fellowships out there. And the model really is immersion in a resource-denied community rather than immersion in a say an ivory tower like UCSF. Not that there are not underserved people being seen at UCSF, but the day-to-day in Navajo Nation, the day-to-day in rural India is caring for resource-denied communities. And we pick and choose our partners very, very carefully. All of our partners are either public sector health systems or partner extremely closely with the public sector. Almost all of them have community health worker models. They all do horizontal care rather than vertical care. And I would say probably 95% of our partners are in rural settings. And many, probably more than half of our partners care for indigenous populations. Okay, so here's HEAL's financial model. That I think another financial innovation that allows us to have a large fellowship and also have some significant sustainability. Even though we do have a requirement for philanthropy, it is, at least over the past 8 years, we've shown that it's sustainable. So our major revenue source is the Indian Health Service, so government contracts. And the reason that HEAL is a good value for Indian Health Service is that right now in many of the Indian Health Service areas in the US, the vacancy rate for physicians could be upwards of 40%. In some places, it could be 50%. In Navajo Nation, historically, it's been around 30%. And so how the government fills those vacancies often is through temporary contracts with what we call locum tenens agencies. Let me know if these are unfamiliar. We can explain more, but locum tenens agencies are almost uniformly for-profit companies that really just try to fill these positions without really aligning their mission with the communities or with the healthcare system. So HEAL comes in and says, what if we can compete with the locum tenens contractors, but we are providing a great deal of value, way more than the locum tenens. So because we're not only recruiting great doctors, fully trained doctors, but also we have fellows who are picked from the communities that would lead to more long-term change in the system. Our fellows have also been proven to, many of our graduates will stay in those communities. So we've had over a dozen graduates actually take full-time jobs in Navajo Nation, therefore filling those vacancies.
It's like 25 people have stayed in Navajo Nation after the fellowship. So for Indian Health Service, that was an unexpected, boon, because when you have a 30% vacancy and having that much retention after has been great.
So this is our model for, and that's why I consider this a redistributive justice model, because the funds that would otherwise have gone to a for-profit staffing company are now being shifted to train and provide resources for one Indigenous health leader, one Global South health leader who become our site fellows, who get these MPHs, who get the community of practice and the HEAL curriculum and mentorship for those 2 years. All of that is done at no extra cost, let's say, to the government. So what we charge the government, the Indian Health Service, is what basically the locum tenens industry would charge, and sometimes less. The math doesn't work out exactly 100%, so we're not completely sustainable. So we do rely on philanthropy to really drive our engine of innovation, to drive our ability to iterate on our curricula, to hire staff and faculty. But I can go to the next slide.
And just to add, I think, we've tried to think about how to work with nurses being rotating fellows, and some of the finances are a little bit harder and require more philanthropy. And on the far end of the spectrum, like surgeons and anesthesiology, because there's, in the financial market, their pay scale is so high, like they are able to cross subsidize a lot. So we've had a number of surgeons, a number of anesthesiologists as well.
There's a question. Should we take a look at the question? Okay, yes. So can you speak to the international placements and how they're, so they are exactly funded.
Just repeat the question, because
sorry.
Yes.
participants in the webinar count.
So can you speak to the international placements and how they are funded? So yes, this is, I can go back one slide. This is what I mean by redistributive justice model, is that the money, let's say on the right, the staffing agency, the for-profit staffing agency that would fill the position if HEAL were not in existence, that same pot of dollars, now HEAL competes for those dollars. And if we get that money, then that money pays for the Global South, the international component, which includes all the travel and the training when we bring the fellows together, the MPHs, the staff time, the faculty time, and the cost of building that community of practice. So it's all embedded. And it doesn't work out to balance the budget, which is why we still have to backfill our with philanthropy. We can go to the next slide.
And traditionally, I think the international sites have contributed what they can. So in-country travel, housing, sometimes food, and then occasionally they'll put in the cost of flights. So it's really not having a barrier for international partner sites.
Right. I mean, we also we don't want to overlook the enormous in-kind contributions of our international partners when they are hosting a fellow. There's a huge cost to carrying, hosting a fellow, even if that can't be dollar signs cannot be placed next to it. There is a lot of commitment and hard work. So here's where HEAL is still, you can see here, it's still dependent on philanthropy, but not wholly dependent on philanthropy. We often talk about philanthropy just basically leveraging HEAL's ability to get $4 of government to secure $4 of government contracts through Indian Health Service for every $1 of philanthropy. So in HEAL's existence so far, which is about almost 8 years now, we've raised almost $3 million in philanthropy, but at the same time, we've secured $13 million in contracts. So it's this is another part of the HEAL model, I think, that is relatively sustainable. Even if we can't raise a single dollar in philanthropy, we could still run the fellowship very bare bones, but it would be very hard to innovate and spend money on iteration of the curriculum, for example. Here are where our partnerships are. The majority of our domestic partnerships are in Navajo Nation, although we are now looking to expand. We actually have expanded beyond Navajo Nation in terms of new partnerships in the U.S., including the Zuni Nation. And then in Pima County, we also have a partnership in California in a farm worker community called Salinas, California. And then you can see here many of the other partnerships around the world, including many that are PIH affiliated organizations. Okay. Okay, so Sri will take over. Can we see if there are any other new questions?
I don't think there is.
Okay, go ahead.
All right, so we definitely want to leave some time for discussion. So I think when COVID hit, as I think all of us were impacted deeply and stretched, and Navajo Nation, I think in March of 2020 had one of the largest surges in March of 2020. I think it was the highest rates of COVID per capita in the world. And so at that time, we'd been working for 6 years in Navajo Nation, and the respiratory care units were, at close to being shut down. There was nursing workforce shortages, and HEAL, like we had mentioned, the rotating fellows are mostly physicians. So we didn't have a ton of nurses, and we kept getting calls from our partner sites. Dr. Adrian Begay, who was one of the leads at Gallup in the Indian Health Service, was talking to us about requesting nurses. And so at that time, we started talking to the C-suite at UCSF, and it was kind of an ideal time because San Francisco had shut down, and had a lot of nurses that weren't working, but also the clinical side at San Francisco wasn't busy. And so we hadn't surged. And so at that time, from about March of 2020 to August of 2020, HEAL facilitated about 50 nurses and docs to kind of keep respiratory centers open. And we spent a lot of time with a focus on solidarity and the ways to have this relationship between an academic medical center, UCSF, and Navajo Nation be equitable and based on, because there was all, like we mentioned in the Haiti after the earthquake, there's a lot of volunteers coming into a context that they didn't have that much familiarity with. And so HEAL spent a lot of time kind of educating the volunteers and setting them up to do some of the work. And so COVID and Navajo Nation, I think, as many of us know on this call, there's just the tip of the iceberg when you see a pandemic, and oftentimes it's such a rural place that many folks that aren't familiar with Navajo Nation would say, why is there surge in Navajo Nation? But if you look at H1N1 and you look at other pandemics before that, it ends up hitting, as we know, people that are vulnerable in communities that are poor. And so COVID and Navajo Nation, you can see this list here. Underfunding of Indian Health Service, despite healthcare being a treaty right for Native Americans, it's funded at 1/3 the rate of Medicare. There's a 30% vacancy, like we mentioned, and then you can go down through here. And oftentimes, I think the narrative that was told was about diabetes and obesity and living in close quarters. And so there's this language that you saw that I think Heal pays attention to, and all of us pay attention to, as the language of blame on patients or vulnerable communities, and how to retell that narrative in terms of genocide, historical trauma, racism, underfunding of Indian Health Service. And so, like I mentioned, we were during the first part of the pandemic, during kind of a very, very difficult time for Navajo Nation. Heal was able to have UCSF nurses support a lot of the Indian Health Service hospitals and some of the tribal hospitals in Navajo Nation. And so I think that one of the things that we train our fellows on is the public narrative, which is as the Marshall Gans, who's here in Boston, that has led this, like, when you're building movements, how do you tell the story of movements? And oftentimes the narrative is told from a colonial lens, or it's told from a heroism lens. And so this was one of the things that we were thrown into during COVID, where when we were coming from San Francisco into Navajo Nation, a lot of times the media lens was to talk about kind of this academic medical center coming to save the day in Navajo Nation. But I think the truth is we had a lot of relationships with Navajo Nation before the pandemic, which built that strong solidarity. And the president of Navajo Nation, the former President Nez, and the leadership in Navajo Nation was very, very strong. And they had like numerous lockdowns. The Navajo people had complied with like mask mandates and lockdowns for a longer period than most people in the US. And so the leadership was quite strong. And so one of the efforts with HEAL was to reshape, as part of doing the work of the solidarity effort of keeping the respiratory care units open, was how do we shape the narrative? And that's such an important part of, whether it's COVID equity, vaccine equity, or in this case, I think the story the media tended to lean on was the story of outsiders coming to support Navajo Nation, and really shifting that conversation. And so because we had a lot of strong partners in Navajo Nation, a lot of the grand rounds that UCSF had, instead of me speaking, it was Dr. Adrian Briguet or other Navajo fellows, alumni, that would lead the conversation with UCSF. And so I think that was also something that, as we think about global health and global health equity, whose voice kind of speaks for what's going on, and how do we lead that narrative. This is a slide, I mentioned this, the Indian Health Service spending per user is lower than Medicaid and Medicare, and that's something that's an active policy effort by many people. I think this slide, is part of, it's a very busy slide, but I think the largest, when there was an outbreak, you can see that at the church gathering, there's a large church gathering, I think in February 2020, and there was an exposure for a population that was marginally housed and in a detox center. And so, on the surface, one of the things that we tell our fellows is, how do we look at the root causes of suffering, the root causes of disease, and so really being able to look at, if there's a COVID outbreak, there's actually a lot of history that goes into it. On the orange side of the slide, there's a lot of history that goes into actually the COVID infection, right? And so this slide is kind of shaping what we all know as structural determinants of health driving outcomes. And so this is something that one of our mentors in HEAL teaches our fellows. And our impact to date, I think a lot of the strength of HEAL, the quantitative impact has been a lot of retention of rotating fellows in Navajo Nation. So in our first 6 years, like 1 in 3 fellows actually stayed on. OBGYN, for example, we worked ourselves out of a job where a lot of positions in Navajo Nation were filled by OBGYN, and so we started to actively look for other sites where we can work for OB. And then the U.S. government there was a U.S. government report, I believe, before the pandemic that talked about, could these fellowships be, and they named HEAL as one strategy to address some of these large vacancies in Indian country. So one of our principles is the work is everywhere. And so I think for us, it's really important to be grounded in US context. So some of the voyeurism that can be inherent in global health is grounded by committing to domestic work, whether it's Oakland or Central California or Navajo Nation. And then these are some of our international sites. Oh, there's a question here. Let's see. Is my apologies, I may have missed this. Is your program training fellows to work with Navajo Nation? Navajo fellows to work with Navajo Nation? Yes. So I think as Phuoc talked about the model, when we started, the Indian Health Service is paying for a service contract to fill these vacancies. But because we're committed to a redistributed model, we support Navajo fellows to join. And so there's been 60 plus Navajo fellows that have been part of HEAL. And now the CMO of Indian Health Service is really working with us to think about how do we embed that in the actual program and the contractual work, because as we all know, the US government, shifting from a clinical service contract to professional development or a program that actually supports the Navajo Nation professional development is kind of a different funding line. But I think they've seen the benefit, especially during COVID, with all these Navajo fellows that have come through HEAL, have taken up leadership positions in Navajo Nation, and have really been really strong as leaders. They were before HEAL, but also because of HEAL as well. Other things that.
No, let's maybe do another 5 to 10 minutes so that we can
I
get
think just
questions.
5 minutes. I think that we only have a couple more slides. I think the future strategy of HEAL is really continue the 20 to 25 fellows in this transform pillar. And then one of the things that we're trying to do is, I think there has been a really strong transformative quality to the HEAL program. And so this also came from site fellows where, our Mexican site fellows would say wow, it's amazing that we're joining, but there's 20 other folks that don't speak English that want to participate in something like HEAL. And so through that, we've started a Chiapas-based Southern Mexico with our partners at SES to have a monolingual Spanish HEAL program. And so it's the curriculum is adapted into Spanish. It's run by our alumni. HEAL's hired a coordinator. And so community health workers and other nurses that wouldn't access necessarily HEAL because they don't speak English are doing a HEAL program based in Chiapas. And so that's one of the goals is to reach more health workers. And then lastly, one of the pieces we'll talk about is how do we collaborate with other academic medical centers to kind of drive this global health equity fellowship model. So we'll touch upon this briefly. I think there's a lot of, because of our COVID work in Navajo Nation with UCSF being very visible, we presented to the regents of California. So the University of California system is several medical schools and several undergraduate campuses, so kind of a large public system throughout California. And they have become interested in this conversation of how would we replicate HEAL across the UC system, and how would academic medical centers in the University of California system work in their geographic proximity to support, Latinx, Black, Indigenous workforce that are from rural parts of California. And so I won't go into this too much. Do you want to talk about this piece?
Sure. Let's see. What is the rate of return of these fellows to build careers in these or similar locations? I do these fellows start careers in Navajo Nation? Thank you for your question. So yes, I think one of the metrics of success is because we want our fellows ideally to have an entire career in underserved care. So for our site fellows, the ones who are from LMICs or from Navajo Nation, greater than 90% of them are retained in that space. So they either continue their work and take on leadership positions. We've had many fellows from Navajo Nation or from LMICs take on positions of increasing responsibility. Like I mentioned, part of the curriculum has a heavy component of leadership training. And then of our rotating fellows, those who are not from those communities, like Sri said, 1 in 3 have taken full-time jobs after their fellowship in Navajo Nation, thereby filling really crucial vacancies. And in some instances, HEAL has worked itself out of a job because there are no more vacancies in certain departments, which is a good thing. That's a great thing when you work yourself out of a job. And that's one of the reasons why HEAL has started partnering with other tribal nations such as the Zuni and others in South Dakota as well. I hope that answers your question. Okay, so our third strategy, Sri already mentioned, we're undergoing a design effort to see if the HEAL model can be replicated at other University of California campuses, and we are in the early stages of that. So if you look at the state of California, there are 2 primary urban areas, central of the Bay Area and SoCal. But if you look at the entire north, that's called the North State, it is extremely rural, very sparsely populated from a density perspective, and high needs of communities in terms of access to healthcare. And California also has more than 50 tribal health programs. Most of them are in rural settings. So I work as a primary care doctor in one of those tribal health settings, where it took us 3.5 years to fill 1 physician vacancy. And during that interim time of those 3.5 years, we've continued to use that locum tenens model, like I mentioned, that for-profit model to fill. So I think the HEAL model in California, working with underserved communities, FQHCs, or critical access hospitals and tribal health programs, there's certainly a need, and hopefully there'll be some uptake there. Our other approaches in terms of expanding our collaboration is and I think some folks on this Zoom call are part of a consortium of academic medical centers that have fellowships embedded within work in Indian Health Service. So there are around 7 or 8 of us academic medical centers, including actually Mass General, University of Utah, University of Washington, that when we're all sharing resources, sharing knowledge, and sharing our power to make to support federal advocacy efforts, so that more resources from the graduate medical education perspective come into Indian Health Service. So, for example, right now, there is no GME office for IHS like there is at the VA. There's a big enterprise in the VA for fellowships and residencies. That doesn't exist in IHS. And we're working with many partners to increase funding to develop more GME opportunities within Indian Health Service. So those are a few of our approaches. And hopefully this work, even though it's a small part of HEAL's work, HEAL's main work still is running the fellowship, but hopefully in the next few years, these strategies will bear some fruit.
And the GME is, we all know where you train is more likely where you stay. And so having GME residency spots at IHS, I think is a big push, and it has bipartisan support. So hopefully it's just a matter of time.
I think that, yes, in the interest of time, I would love for folks to come on screen and unmute yourselves if you have questions.
So it's a webinar, so they can't.
Oh, sorry.
Questions.
Okay. I apologize.
So Maybe we can put the screen back up with Serena and Joe, the other panelists. And if anyone has questions, please go ahead and put them in the Q&A. We do have one lined up there, and maybe Serena or Joe, if you wanted to.
What is the potential to expand the fellowship services in new sites in LMIC communities? If yes, what is the process? Great question. And we've had, early in HEAL's existence, we probably partnered with too many organizations. I think we had 13 partnerships, and we proved to be too many because there's a lot of relationships to maintain. And so HEAL is extremely careful about what our own ability to maintain high quality partnerships is. But with expansion into other University of California campuses, there are certainly opportunities, I think, to have partnerships with health systems in LMICs. And so anything else you could add to that, Sri?
No, I mean, there's been a lot of places that see the benefit and have approached us, and we, I think we have to just be careful about how large we get. But with California, I think with the other academic medical centers that have replicated some of the financial models, having more LMIC partner sites be able to join those academic fellowships rather than HEAL kind of expand our partnerships, I would say.
Serena?
Thank you for a really fantastic talk. This is incredible work you're doing. My question is whether you are currently or you plan to embed research into this work, because you could just see how outcomes would improve with shifting towards longer term people very dedicated to communities. Or you may think, boy, we could do this better if we, had this community-based strategy. So could you talk a little bit about your thoughts on that?
Sure. I think from the very beginning, we very purposefully designed the fellowship to be a global health delivery fellowship, where the most important part of the fellowship is actually day-to-day seeing patients and helping to improve health systems, rather than, so we never have required a research component. Although some of our fellows have done research, it's almost uniformly research that is driven by the partner, driven by the health system that they're working in. And so they're assisting in that effort. We are super careful in claiming like health outcomes, because it's really hard, I think, to prove that a fellow actually increases or decreases, like under 5 mortality, or reduced food insecurity, or another hard metric like that, because just of the nature of the so many variables. We obviously don't have controls, and so we usually, our metrics are, I would say, more soft metrics, like what the careers are of our fellows, how many leadership positions they take, what's the retention rate, and even things like how many patients are seen. But those are quite soft. We can understand soft metrics. I'd love to get Serena, do you have any ideas on how we can do that without having just a massive shift in the way, in terms of like the work that the fellowship does?
Well, I mean, I want Joe to be able to talk, but we could certainly talk on fly. I just love research because I love measuring things and then thinking, how can you do this better? But, like even patient satisfaction, how do you feel? What was your waiting time? I just think there could be so many ways to embed, not really research from the community saying that would be an interesting study, or we could do this better, or what if we did this? But I agree, absolutely led by the local communities with the sole goal of improving care delivery.
I think, Navajo Nation, obviously the IRB and the doing research, I think now we've built a lot of trust that, when you start off a partnership, especially Navajo Nation, I think it's very hard to start with a research lens. But, a lot of our partner sites, they really want to do research. Oftentimes they're so stretched, and they might have not had the research capacity or the support. And so building up research capacity is something we hear again and again. And HEAL just hasn't, we've done a lot of internal metrics of like exit interviews of our fellows and what is working on the HEAL side, but not, how do we actually embed more research and into the day-to-day work in a way that's sustainable and in a way that's coming from the communities we're serving.
Thank you, Joe.
Can I ask, thanks for the amazing talk and just incredible work. I mean, it's really been transformative in global health education and workforce development. Can you guys talk just a little bit? I know you've spent a lot of time thinking about the curriculum that you deliver to the fellows, both internationally and locally, and the way you're able to create such a like-minded group of folks that you meet, fresh every year. I know you've thought about that a lot. Can you talk just a little bit about that to give us some insight?
Well, I'll just start, and then Sri knows a lot more than I do. But we started out, at the very beginning, 2015, we actually hired a consultant who is a EDD in pedagogy to help us with the curriculum development, just the approach to it. And so we actually used the 6 competencies of the ACGME, even though we were non-ACGME accredited fellowship. We still use those same 6 competencies, and one of them being clinical competence, which turns out our fellows are so diverse from an interprofessional standpoint that we can't just layer some random competencies from the ACGME onto a global health fellowship. So then we, over time, developed these 4 pillars that I mentioned. And every year it's iterated, and every year more and more of the curriculum is delivered by alumni from the program itself. And actually fellows, current fellows teaching themselves is a huge part of the curriculum. Sri, anything else?
Yeah, I mean, the 4 pillars really that we anchor to is leadership, advocacy, structural competency, and power and privilege. And I think one of the exciting pieces has been case studies that have come from our fellows. So for example, in the leadership space, there's a case from rural India, Saver Rural, where we work, where there's 6 patients in the morning on cataract surgery that become blind, and the leadership team is thinking about how to disclose this, how to talk about it to the patients, how to talk about it to families, the funding streams that come from the government and managing those relationships. And so then he, the fellow that was part of this conversation puts it to the larger group, and there's a discussion, and then they come back, and it turned out to be a contaminated saline that had infected these eyes. But so that level of case studies that are coming from our fellows and actually teaching. And so now, I think there's a lot of innovation around having like a 2-page case, like a fellow who's an alum do like a 5-minute video kind of explaining what happened, and they could do it in a few parts. And then so you could have this component of a video with the alumni, and then the fellows discussing it. And so we're doing that across a lot of our sites, and we're starting to have a lot of cases that are from the work itself.
There's a question in the chat. Okay, so we're almost done here. I am a biomed at MGH and have done some global health work in the past. Do you have any groups you partner with to help with equipment infrastructure support at the sites?
Good question. I can't say that. I mean, because our partner sites are pretty robust in their own supply chain, and we have focused on the staffing and the support of health workforce and professional development, and haven't kind of delved that much into the supply and the stuff. So
I'm going to jump in because I know that message is from Tom Monahan. Hi, Tom. So Tom spent many years in southern Haiti developing a biomedical training program and training folks there, and has worked also with us in Uganda to train biomedical technicians and engineers. So I think
Wow.
that's what he's getting at, professional development wise, not supply chain wise.
I see, I see. We have not had a biomed a profession join the fellowship, although I'd be, I think Heal would be very open to that. It's so important. How many CT scanners are sitting literally broken, around, not just CT scanners, but even EKG machines are just
Yeah.
not working, just sitting. This happens again and again, right? Because there's no focus or minimal focus on having a biomed workforce. That's a very good question. Thank you.
So we are at time, and I want to thank you both very much for being here in person at Mass General today for our first hybrid grand rounds since the pandemic. And thanks, Serena and Joe, for joining from where you are, and everyone else for joining online. Thanks. See
Thank
next
you.
time. Bye.
Thank you.
Bye. Bye, Joe.